Welcome everyone. Today I am going to discuss some previous year questions of DNB Medicine. It will be helpful for those who will be appearing for their Medicine MD exam and for MBBS final year medicine exam as well. So it is also based on Harrison's. So the first question is, what is evidence-based medicine? Sources of evidence outline the advantage and disadvantage of such an approach as decision support tools. This was the question of June 2017, and a similar question was in 2011 as well. Similar questions 2011 twice and 2010. So coming to the answers, what is evidence-based medicine? Evidence-based medicine is the consensus, explicit and judicious use of the best available evidence from scientific research to make decisions about the care of individual patients. Evidence-based medicine integrates clinical expertise, patient values, and the best available research evidence to ensure optimal outcomes in patient care. What is the principle of evidence-based medicine? Principle is it is the best available evidence. EBM relies on using high-quality, up-to-date research from clinical trials, systematic reviews, and meta-analysis. The best evidence typically comes from a well-designed RCTs and systematic reviews of such studies. Then clinical expertise. While research evidence provides general guidelines, the clinician's own expertise and experience in diagnosing and treating the patients play a critical role in applying the evidence to individual patients. Patient values and preferences. EVM emphasizes the importance of considering each patient's unique circumstances, preference, and values. Patients may have different goals, beliefs, and concerns, and these should be factored into decision making. The process of practicing EBM. So first is formulate clinical questions using the PICO framework. Remember PICO. PICO, P for patient, I for intervention, C for comparison, and O for outcome. Clinicians develop focused answerable clinical questions. First is P, who is the patient or population? I, what is the intervention being considered? C, what is the comparison, if any? And O, what is the outcome of interest? Search for the best evidence. Clinicians search medical databases like PubMed, Cochrane Library to find out high-quality, relevant research strategies and clinical guidelines that addresses the clinical questions. Then 3. Critically appraise of the evidence. Once evidence is gathered, clinicians must evaluate the research for its validity, reliability, and applicability. They assess the quality of the study design. Example, RCTs are preferred over observational studies, sample size, and outcome. Fourth is apply the evidence to clinical practice. After assessing the evidence, it is integrated into the care of the patients, taking into account their individual clinical situation, risk, and preferences. Then fifth is evaluate the outcome. The impact of the decision or treatment is monitored to ensure that it leads to the desired patient's outcome. Adjustment may be made based on patient response. Then coming to sources of evidence. So what are the sources of evidence? The sources of evidence in evidence-based medicine comes from variety of research methods, clinical studies, expert opinions, and databases. These sources are ranked based on the quality and reliability of the evidence they provide. The strongest evidence typically comes from a well-conducted clinical research, especially RCTs and systemic reviews. Then coming to type of sources of evidence. First is systemic reviews and meta-analysis. Systemic review, systematic reviews and meta-analysis. Systematic review, a comprehensive review of all relevant studies on a specific clinical questions, following predefined methodology to minimize bias. Meta-analysis, a statistical technique used within the systematic review that combines data from multiple studies to derive a pooled estimate of treatment effects. Example, Cochrane database of systemic reviews, Prospero. Its strength is These represent the highest level of evidence because they synthesize data from multiple studies and provide clear overviews of the effectiveness of risk and interventions. Then RCTs, randomized controlled trials. RCTs are considered the gold standard for clinical research. Participants are randomly assigned to either the treatment group or a control group, placebo or standard care, minimizing selection bias and allowing strong inference about cause and effect. As example, PubMed's clinicaltrials.gov, and its strength is RCTs provide high quality evidence, especially when well designed, as they reduce confounding and factor and bias, giving reliable conclusions about the treatment efficacy. Then third is cohort studies. Observational studies that follow a group of individual, uh, like called cohort, over time to assess outcomes, disease or incidence, based on exposure and risk factor for treatment. Cohort studies are useful for studying the long-term effect of exposure, but are more prone to bias and compared to RCTs. Then case control studies. These studies compare individual with a condition like cases to those without the condition in they are called controls, looking retrospectively. This is a retrospective study to determine the exposure or risk factors that may have contributed to the outcome. uh, Case control studies are useful for studying rare conditions but are limited by recall bias and the inability to establish causality as strongly as cohort studies or RCTs. Then case series or case report. Description of individual or small group of patients with particular conditions and treatment or outcomes. Its strength, they are useful in generating hypotheses and identifying novel conditions or treatment effect, but lack the statistical power and control over confounding factors, making them lower quality of evidence. Then, clinical practice guidelines. Guidelines developed by expert panels based on systematic review. The evidence they provide a recommendation of clinical practice. Its example are like NICE guidelines, National Institute of Health and Care Excellence, USPSTF, US Preventive Service Task Force, Guidelines Interventional Network (GIN). Guidelines synthesize a large body of evidence and offer practical evidence-based recommendation for healthcare providers. Then, last is expert opinions. When high-quality evidence is unavailable, expert opinion based on clinical experience and knowledge may serve as a source of guidance. Its strength, what is its strength? Uh, while important in situation where evidence is lacking, expert opinion is considered the lowest level of evidence in EBM because it is subjective and prone to bias. Then number 8 is clinical database and registries. Large database of disease registries collect data on patients' outcome, treatment, and risk factors, often from a large number of patients and over a long periods. Strength: these sources provide valuable real-world data, especially of assessing long-term outcomes, but may be subject to reporting bias. And then common database and research for evidence-based medicine. PubMed, a widely used biomedical database providing access to a broader range of research articles, including RCTs, cohort studies, case reports, and systematic review. Cochrane Library, a collection of high-quality systematic reviews and meta-analysis regarded as one of the top resources of evidence in healthcare decision-making. MBase, a comprehensive biomedical database with a focus on pharmacology and drug research, including trials and systematic reviews. Then clinicaltrials.gov, a database of privately and publicly funded clinical trials from around the world, providing information on trial designs, interventions, and outcomes. TRIP database, a clinical research engine designed to find high-quality clinical evidence of healthcare professionals, including clinical guidelines, systematic reviews, and evidence synopses. NICE, National Institute of Health and Care Excellence, a UK-based organization for providing national guidelines and evidence-based recommendation of healthcare. Then coming to hierarchy of evidence. Okay. The quality of evidence is often categorized in hierarchical model. The highest level is given to systematic review and meta-analysis. Then number 2 is randomized control trial. Number 3 is cohort study. Number 4 is case control study. Number 5 is cross-sectional study. Number 6 is case series and case reports. And number 7 is expert opinion or lowest level. Then second part of the question, what are the advantages and disadvantages of such approach as decision supporting tools? So using evidence-based medicine as a decision supporting tool in clinical practice offers both significant advantages and potential disadvantages. So looking for it, advantage. What are the advantages of EBM? It improves patient outcome. EBM ensures that decisions are grounded in the most reliable and up-to-date research, which generally leads to a better outcome of patients. Treatments and interventions are more likely to be effective and safe when supported by high-quality evidence. Standardized care. EBM helps standardize clinical practice by providing guidelines based on the best available evidence. This reduces variability in treatment approaches across the different clinicians and setting, improving consistency in patient care. Efficiency in decision making. EBM tools provide clinicians with a quick access to relevant research, clinical guidelines, and protocols, speeding up the decision making process, especially in complex cases. This can be particularly useful in high pressure environments like emergency medicine. Reduced unnecessary interventions. By adhering to evidence-based medicine guidelines, clinicians can avoid unnecessary tests, treatment, or procedures, which reduces healthcare costs and the risk associated with over-treatments, like side effects, complication of unnecessary surgery. Patient-centered care. EBM encourages incorporating patient preference and values into care decisions. This aligns treatments with the patient expectations, beliefs, and lifestyle, improving patient satisfaction and adherence to the treatment plans. Encourages lifelong learning. EBM keeps clinicians engaged continuous learning by emphasizing the importance of staying up to date with the latest research and evolving practices. This helps improve clinical knowledge and practice over time. Enhanced collaboration. EBM promotes collaboration among healthcare teams by creating a shared language and framework or discussing patients' care based on the high quality evidence. It can be It can also be enhanced multidisciplinary approach to complex conditions. Then coming to the disadvantage, what are the disadvantages of evidence-based medicine as a decision supporting tools? Over-reliance on evidence, lack of personalized care. EBM focuses on population-level confidence evidence, which may not always be applicable to every individual patient, especially those with unique characteristics like rare conditions. Strict adherence to guidelines might overlook the importance of nuances in individual cases. One-size-fits-all approach. Some guidelines may not accommodate the complexity or variability of the real-world clinical practice, leading to overly rigid treatment protocols that may not be suitable for all patients. Then, limited availability of high-quality evidence. Lack of evidence in some areas for rare diseases, emerging treatment, or unique patient populations. Example, pregnant women, elderly patients with multiple comorbidities, high-quality RCTs or systematic review may not exist. In such cases, clinicians may be left with incomplete or low-quality evidence. Publication bias. Studies with positive findings are more likely to be published. You can see that in your thesis also. While those with negative or neutral results may not be as widely available, leading to a potential bias available evidence. Then time and resource intensive. Assessing and appraising evidence, clinicians must spend time searching for and critically appraising evidence, which can be difficult in busy clinic settings. The process of implementing EBM in real time can be resource intensive and may slow decision making, particularly when quick decisions are required. Cost of implementing EBM tools, developing and maintaining evidence-based medicine support system can be costly, particularly for smaller healthcare organizations. Overemphasis on quantitative data. Undervalued clinical experience, EBM tends to prioritize quantitative data such as RCTs, which might overshadow the importance of clinical expertise and judgment. Clinicians with years of practice experience may feel that their expertise are devalued in favor of research findings that may not always reflect real-world practice. Resistance to change. Clinicians' reluctance. Some healthcare providers may resist adopting EBM-based decision support tools due to discomfort with changing long-established clinical practices or skepticism about the applicability of research findings to their patient population. Guideline fatigue. Constantly evolving guidelines and new evidence can be overwhelming for clinicians to keep up with, evidence leading to potential burnout and or confusion. Patient preferences may be overlooked. Potential conflict with patient values. While EBM advocates of the integration of patient preference in practice, it can sometimes prioritize the best evidence over patient's autonomy. For example, a patient may decline a treatment that is evidence-based, and reconciling those differences can be challenging for clinicians. Ethical and legal consideration. Legal pressure to follow guidelines. There may be a legal expectation or pressure to follow evidence-based medicine guidelines strictly, even in cases where patients' individual circumstances warrant deviation from the standard protocols. This can create a tension between what is best for the patient and adherence to the guidelines. Potential for overstandardization. Rigid adherence to EBM guidelines can lead to medical decision making that is overly standardized, potentially undermining the clinician's autonomy in tailoring care and individual patient needs. Okay, that is for the question number one. Thank you.